Me and a microphone, it's dangerous. Okay. How much time, an hour? Okay. Well, let me just start out about this oncology cardiology thing. As many of you, well, I don't think anybody knows this. Perhaps only Mary knows it, and I don't even know if she knows it. Early on in my career, I was actually going to become a cardiologist. And I was all set up to become a cardiologist. I was accepted to a cardiology fellowship program. And I did a 3-month stint in the cath lab during a transition period and did like 50, 60 cardiac caths. I used to do 2 a day. And I said, I can't do this as a life, okay? This is a bore, okay? So my last rotation was at a community hospital in Evanston, Illinois, St. Francis Hospital, and nobody wanted to go there. And I decided, well, this is my last rotation in internal medicine. I'm all set up for this cardiology fellowship. So perhaps I could take this oncology fellowship. And I took it, and I fell in love with it. So in St. Francis Hospital in Evanston, Illinois, I went downstairs to the gift shop and got $5 worth of quarters and started calling up every oncology program in the United States. And everybody said, no, you're too late, we've chosen all of our fellows. So what am I going to do? So my last call was to Rush Presbyterian St. Luke's Hospital in Chicago. And the program director said, somebody just dropped out. You got the job. And I said, well, don't you want to see my CV application? No, just send it in, but come and see me anyway. You got the job. So that was my introduction to oncology, so to speak. So cardiology's loss, oncology's gain, right, Bob? Okay. It's a bore, that field. I don't know how you guys do it. One organ, left main 90%, obtuse marginal 60%, LEV 50%. Okay, I get it. Okay, a bore. Oncology is such a more fascinating field, and it's getting better, folks, as we understand the diseases. Okay, as Rob mentioned, and as I pointed out, this award is not about me. Okay, I really want to make that clear. It's about the excellent groups of physicians and support staff, PhDs that we have working with us, and many of you are here in this room, and I cannot do my work without you. I'll just tell you a very small story. A couple of weeks ago, I got a call from a PA, a physician assistant that I worked with when I was first starting out my career at Wayne State. And during that period of time, I was treating lung cancer, and one of my colleagues, a physician, quit, and I had to inherit his practice. So I had a practice of basically 40 inpatients, okay, that I had to see every single day, plus taking over his clinic. And it was murder, basically, just as a time to see everyone and try to do the work. And I really relied on this PA, and we had a marvelous time working together. And he called me up several months ago, and he said, Rick, I've been reflecting back on my career. It's been basically 30 years since we worked together. And I have to tell you that working with you and working at that experience with you was one of the best experiences of my life. And I said, well, Dan, everything came together at this. It just snapped. We had a great time. We respected each other. We had a lot of work to do. We couldn't get lost with peripheral issues. We really had to focus on what we're doing. And he said, well, yeah, and then we talked about Mary's illness, et cetera. And I said, well, Dan, getting back to the professional aspect, things couldn't be doing better for me professionally. And I said, that time that we had at Wayne State where everything snapped? Well, the same thing has happened at the FDA for me. Everything has come together. We have an excellent group of people that don't generally get lost, not always, but generally we don't get lost in the minutia and the bad things that happen between people. We're focusing on big picture issues here. We have a lot of camaraderie, and I hope myself as a leader of this group focuses on every person's career. Now I know, where's Amy McKee? She's going to cringe when I say this because it's probably politically incorrect, that I take a look at all of the review staff, since they basically are in their 30s or early 40s, as all my children, okay? I have to take an emphasis, or I have to take a view of how to develop their careers, and I want everyone, all of the physicians and all of the PhDs and support staff that work for me, to feel fulfilled that their careers are being built. And if people have that sense that I am for them, it's not about me. I don't need to give another talk. I don't need to get another award. I don't need to give another paper. It's about you and developing your career, that you will realize really the importance of what we do and really how you can develop your career at the FDA. And the next thing I want to mention, as I said, it's dangerous to give me a microphone here, Ellen, is the patient voice. It's hard to say what the patient voice is, and when we were making this film, some of the things that were cut out is, what is the patient's voice? And I really don't think there is a thing such as the patient's voice. It is really a collection, a chorus of many voices, of many different experiences that may change during the course of an illness. For example, the way a person looks at a clinical trial, when there's an adjuvant therapy, when they have a risk of having a recurrence, may be very, very different from somebody that has progressed through multiple therapies that may not have any therapeutic options available to them, and hence their risk-benefit, their evaluation of the treatment, what types of endpoints they may be looking at. But as I mentioned here, I think when we take a look at the patient voice, there's some things that we could say that all patients agree on, that we want clinical trials that really work for us. As I mentioned in the clip, we want clinical trials that have more expansive eligibility criteria that really reflect the patients that are going to be using these drugs. We want expanded access programs that really work for us. I've had 2 calls from former NCI directors that couldn't figure out how to use our expanded access programs. So we really need to work on really facilitating how patients get unapproved drugs. We need informed consents that are meaningful to patients, that aren't just page after page of legalese that nobody reads or people read and don't understand, but we really need to have a better informed consent procedure. So it's really putting the patient in the forefront, and that's what I see as the patient voice, or as I mentioned in the clip, the cry of the patient, really to make clinical trials more patient-focused. I'll just end by saying, what should be the primary endpoint of the trial, a trial? And I see our statistician Raji being there. Should it be overall survival? Should it be progression-free survival? Should it be a response rate? Well, the primary endpoint of the trial should be the patient, and I'll leave it at that. Thank you.